everybody, and welcome to AARC's Big Ideas Theater. I'm your host, Ed Hyland. We've got the honor now of being joined by Dr. Neil McIntyre once again. We had the pleasure of chatting last year, and this year we're talking a little bit about 2017 ATS SCCM guidelines on mechanical ventilation for ARDS. Welcome once again.
Thank you very much for having me.
Dr. McIntyre, tell us a little bit about some of the barriers to effective ventilator discontinuation.
So ventilator discontinuation is a process as patients recover of getting the ventilatory support off of them and getting them extubated and back out of the ICU. It consumes, by various estimates, anywhere from 40 to 60% of the time a patient is on a ventilator. So it's a very important segment of care. And there are important barriers. The most obvious, of course, is they're still too sick. But one of the things we clinicians need to recognize is that a lot of times we, the clinicians, get in the way. We don't properly ventilate them, we don't properly assess them, and we sedate them too much. So there are significant barriers on our part to getting patients off the ventilator.
I'll almost read this next question because I want to make sure I get all the facts
Sure.
right here. But guidelines were published in 2001 by AARC along with ACCP and SCCM. Updates were published this year. How have the guidelines changed? It has been a few years. We've learned a few things too.
We have, but it's been very interesting because the guidelines are actually the original ones are actually standing the test of time. I was privileged to be the chair of that 2001 guidelines committee, and it did involve AARC along with SCCM and the ACCP. And it was a very interesting process. And the literature was carefully reviewed, and 12 evidence-based guidelines were published about how to assess patients on ventilators for withdrawal potential, how to deal with spontaneous breathing trials, how to get the tube out after you've successfully removed the ventilator. And what's interesting is ERS and ATS decided to update these this year, and surprisingly, or not surprisingly, most of the guidelines were left intact. The cornerstone of assessment and spontaneous breathing trials were left there, and it was really a reiteration of how important those original 12 were. The important things that they did add is they wanted to put pressure support as the best way to do spontaneous breathing trials. I'm not convinced of that, but that's what the recommendations say. They really emphasized the role of non-invasive ventilation as an adjunct, especially in the COPD population, and they really pushed on the importance of reducing sedation. They didn't say you had to do spontaneous awakening trials. There's controversy there. But clearly protocols that reduce sedation were included in these updates. But again, I'm sort of proud of the fact that our guidelines from 2001 are still practical today.
If you don't mind me going a little off script, if you
Sure.
will, when will the updates again be considered? And the reason I ask that is because some of our previous guests here in the Big Ideas Theater have research coming out that say, well, perhaps we're leaving them on ventilators a little too long. We should consider shortening the length of time.
You're absolutely right. There are studies out there trying to see if there are better ways of assessing and managing these patients. As I read the horizon, though, I'm not sure these are game changers. I think they are, at the moment, what I know about, may move the needle a little bit.
Okay.
But I don't see new guidelines coming out in the near future.
Okay, and in your mind, a last question, is ventilator discontinuation, extubation, are they the same process?
Yeah. This is a concept that I think is important in reading the literature, because I think all too often in the literature, the process of taking the tube out and the process of removing ventilatory support are treated as the same thing, and they're not. The assessments for ventilator withdrawal involve assessing breathing capabilities, respiratory muscle function, respiratory function in general, mental status, or the control of breathing. That's one process. The second process is, once you remove the ventilator, is getting the tube out. And that's a whole different set, because now you're more interested in, can the patient protect the airway, not be an aspirator, be awake enough to, again, protect their airway and avoid re-intubations. But they are two separate processes, and in reading the literature, it's important to distinguish those two processes.
Dr. Neil McIntyre, always a pleasure and always fascinating.
Thank you very much.
And this is the Big Ideas Theater, sponsored by Draeger.